So based on the article published in JAMA back in 2017 by Murphy et al., we now have a clear understanding on the patients most likely to benefit from home mechanical ventilation and home oxygen therapy. These patients are going to be your sickest COPD patients, the patients coming through the front door of the emergency room who require acute non-invasive ventilation. These patients, after they've survived that life-threatening exacerbation, will need to be reviewed at 2 to 4 weeks, and if they remain hypercapnic with a PaCO2 level, a carbon dioxide level greater than 7 kilopascals, then they should be started on home non-invasive ventilation in addition to home oxygen therapy. The COPD patients you're going to be seeing coming through your emergency rooms are the patients who are going to receive acute non-invasive ventilation. These will be the patients with respiratory acidosis. These are the patients with severe COPD who without acute non-invasive ventilation would have a higher mortality and a higher morbidity. If these patients can be treated with acute non-invasive ventilation, and then we look at the trajectory of change within the carbon dioxide level within the blood. In a patient where the carbon dioxide level falls at 2 to 4 weeks after resolution of the respiratory acidosis, then these patients are actually going to have the same outcome as a patient who has a eucapnic exacerbation of COPD. However, if the patient remains persistently hypercapnic, they will benefit from treatment with home non-invasive ventilation and home oxygen therapy in terms of reducing their admissions to hospital. The timely application of home mechanical ventilation to home oxygen therapy in the persistently hypercapnic patients will result in a reduction in readmission to hospital. Indeed, there is a 2/3 reduction in readmission to hospital at 28 days in patients who are treated with this treatment compared to the controls. There is a 50% efficacy signal in using hot HMV treatment over a 12-month period, such that the patients are half as likely to be readmitted at 12 months if they're given the treatment than if they're not given the treatment. In the hot HMV trial, we used a pressure support mode of ventilation with a median IPAP level of 24 centimetres of water and a median EPAP level of 4 centimetres of water, with 1 litre per minute oxygen therapy entrained at night, and all patients were on oxygen therapy 24 hours a day with a medium flow rate of 1 litre per minute. We have to look at the cost effectiveness and health economics of a treatment to truly understand its benefit. Indeed, when we look at the data from the hot HMV trial and we do medical resource utilisation analysis, what we see is the cost per QALY of £10,360. This equates to an improvement in terms of cost effectiveness. NICE will fund at a level of £30,000 cost per QALY, but indeed, if you are within the last year of your life, NICE will fund up to £50,000 cost per QALY. The patients in this trial, 1/3 had died by the end of 12 months. So indeed, this is a cost-effective as well as clinically effective treatment. There are 3 key references that the clinician needs to be aware of when working in this field. The first is by Thomas Kernlein, that's published in Lancet Respiratory Medicine. This is the German stable COPD NIV study that showed a 21% absolute risk reduction in mortality. So this is an important study for all clinicians to be aware of. The other study is the rescue study, which is the Dutch study, which targeted acute exacerbations of COPD. Those patients who received acute non-invasive ventilation, but after the exacerbation had settled, these patients had a PaCO2 carbon dioxide level in the blood of only 6 kilopascal. And indeed, this was not a positive study. There was no difference between the treatment and control group. However, that allowed us to understand the important work by Murphy et al. That was published in JAMA, which showed there was a difference, but targeting patients with a CO2 level at 7 kilopascals at 2 to 4 weeks, in essence, in the recovery phase.